introduction. And thank you for attending tonight. And thanks, Diabetes UK, for your kind invitation. Now, I'm geriatrician by training, and I've done diabetes as special interest over 20 years. I hope my presentation still exists. No, I can see in this.
Push the plug in.
While you are waiting, can you hear me in the back without microphone? Yeah, it's fine.
No,
So
you need the microphone.
you are sitting as a front seat. Thank you. Anyway, my presentation is about more practical and clinical. I may have used a bit of medical terminology. Please feel free to interrupt and ask if anything is not clear. And it will be better if it is interactive. So anytime, just stop me and ask.
It's waiting for you. I don't know. It's the same. The same. This look is exactly the same as the. So I don't know what that is, but if anything you put there is going to go on there. Okay. I don't know where the slide is or anything.
Is it right up? Oh,
Okay.
with the mouse.
Yeah, thank you. That's it. That's it. Thank you very much. So, thank you. So, this is the media perception of diabetes is mainly linked to obesity, as the media see it. But actually, it is aging is a driving force in addition to obesity. And you can see obesity and diabetes are hand-to-hand, similar to age as well. So this is the two main driving forces for diabetes, not just obesity. And we know that obesity causes diabetes because of the epidemiologic shift, people now moving into cities, and since from 2000 or so, the urban area taken over the rural areas. And when you move to the cities, you get the unhealthy lifestyle and the obesity. Same thing when we get old, we have, I call it the diabetogenic effect of aging. At the pancreas level, our beta cells becomes less in number and less in function. So we produce less insulin than younger people. This is the central level at the pancreas. Peripherally, also, we don't use insulin efficiently as young people. Although we are this two comparison of a young and old man, they have the same waist circumference, but as we get old, we have less fat under the skin, and the fat mainly hidden in the inside our bodies, in the viscera, and this fat make our insulin resistance high, or our use of insulin less efficient. So we become producing less insulin and producing it less efficiently, so are more vulnerable to get diabetes as we get older. Now, this is no surprise, epidemiologic shift. All patients now with diabetes, at least 50% of them are above the age of 65. That's why you see someone like me taking over from Professor Tesfaye. Geriatricians should be more doing diabetes patient in the future. And when you have diabetes in old age, it comes with a problem. So old age have its own problem with physical dysfunction and morbidities. And also this is mainly physical health, but also mental health, mainly dementia and depression. So diabetes is not a single disease like what you expect in someone young, type 1 diabetes. In old age, diabetes is part of another complex conditions. You go quickly through this one. Physical function, all the study you can see, anything on the side means your diabetes risk increases as compared to someone without diabetes. almost double the physical dysfunction when you have diabetes. Same thing when you have also cognitive dysfunction. The risk of dementia, for all dementia, for Alzheimer's disease, or for vascular dementia, all increased by diabetes. Almost double the risk for someone with no diabetes. So this can give us what is the diabetes phenotype in old age. As geriatrician, we use the word geriatric giants or geriatric syndromes. So all this come with older people, and this used to be 5 conditions like incontinence, dementia, now becoming a lot more. And I refer here to virility is another thing important. Professor Sinclair addressed that. But also sarcopenia, which means you have less muscles or less muscle power. And this is important. So it's becoming a complex disease, and diabetes increase the risk of all that. Now, personalized medicine comes, I think Professor Sinclair referred to precision medicine, and personalized medicine, as if you compare someone young who is 20, have diabetes, and he has only single disease, and he's healthy, so it is very easy to write guidelines for a group of people who have similar disease and nothing else. So it's easy to generalize guidelines on a homogeneous group of people. Type 1 young people is easy to put one law, all apply to everybody. When you get to older people, you can have a big spectrum of someone who is 80 years old and is very fit, someone 80 years is bedbound in a nursing home, and in between you get different people with different functions. So it's difficult to generalize guidelines, to tailor it to one person specific, and all the people group are quite heterogeneous and mixed. So individualized or personalized approach is the right way. So in all the people, I highlight these 3 areas, which we have dementia is common, we have seen it, and the main thing related to diabetes is erratic eating pattern. When you have diabetes, especially in insulin, you should have regular eating pattern to get control of your blood sugar. But this eating pattern in dementia make diabetes control difficult. Hypo is another issue, and I put here a typical presentation. As we get old, we do not present with the normal classic hypoglycemia symptoms. We present with weird things. And also you get frail. And frailty associated with significant weight loss. And this also need your hypoglycemic therapy to be dynamic to match your weight, because this is variable and give you a risk of hypoglycemia. So if you start the hypoglycemia, all these are risky factors. So the older the age, the lower body weight, comorbidities, and all of this increase your risk. Organ dysfunction, you can't get rid of your insulin or medications. Also, if you have multiple comorbidities, you have multiple medications. And this medication interact with each other, everyone competing. So the risk of hypo is higher. So I put here hypo in the center, and it interacts with cognitive function, physical function, and also combination of cognitive impairment, physical virility. They call it cognitive virility. It's a nice name. I'm not sure about clinical significance of it, but hypoglycemia in the center of all these complications. And the relation is reciprocal. Dementia increases hypoglycemia risk, and hypoglycemia increases dementia risk, and so on. Now, a typical presentation. This is, I was in my clinic, and one of my patients, I still remember him very well. I asked him, we need to increase the insulin a bit, your blood sugar a bit high here and there. And I said, listen, doctor. He was a bit, I was this beginning of my career. Listen, doctor, if my blood sugar below 6 or 8, I'm not very well. So I was smiling a bit, and I said, what happened if you're not well? I just not very well. Anything specific? He said, not very well, and he's very clear. And he wasn't this guy who have, if you have high blood sugar for a long time, and you get blood sugar down to 6, you feel unwell. This, we call it relative hypoglycemia. He wasn't one of those. He was normal controlled diabetes. So he wasn't what we call relative hypoglycemia. He was normal one. So with his action with me, I decided to ask all my patients. So I get my SHO to do a simple audit. And we published this one. hypoglycemic symptoms and hypoglycemic solution. I wanted to hear from the patients themselves what the hypoglycemia symptoms they have. So we asked them two questions. My SU asked two questions. I only included people who are in insulin because they monitor the blood sugar, they know it. And people also not dementia, so that they can understand what we ask. So two questions, simple question. What is the best blood sugar level you feel well with? And if it drops below this level, what do you feel? Simple two questions. And this was the answer. The blood sugar, mostly, hypoglycemia in the books defined as anything below 4. Now there is no one here 4. The lowest is 5, and majority are between 5 and 9. So hypo threshold in older people could be higher than 4 we've been taught in medical school. Although the sample we have is only few number of patients, but this is the mean range. 6.7 is defined as hypo by patient perspective, not medical textbook. And the range could be 9. People feel not well below 9. It varies. And these are the symptoms. These are patient words, what they say, what they feel. It's different from textbook. It is very non-specific, feeling but strange things. And people have more than one symptom. And when we get more experience in the world and working, you can see people in the medical world, people who are very old, especially the nursing home ones, the frail one, the small, they sit like vacant, they are not responding well. We call it hypoactive delirium. This is the medical terminology, who are less engaging or not taking their tablet, they don't like to eat. These people may have hypoglycemia without really the classic sweating and tremor or anything. So if their blood sugar is 5 or 4, I still cannot rule out possibility of hypoglycemia. I have to get the blood sugar up. So this is something to also bear in mind. That hypo in older people is not 4, most likely above this. And this avoid hypo, I just would develop some acronym when you publish this paper, just how to avoid it. I'm trying to, I don't know about you have your concern here showed to me. I hope this will cover some of it. So it just risk of hypoglycemia need to be addressed and monitor blood sugar. I just put the acronym as possible to help to be aware of hypoglycemia. The second thing is dementia. It's very important, dementia, because when we do annual review, when I was a registrar, I work in diabetes clinic, dementia wasn't part of annual reviews. Annual reviews at the time focus on diabetes complication, mostly vascular, look at the feet and the pinpricks and albuminuria and extras. But there was no assessment of cognitive function or physical function in medical diabetes clinics. This is something we do now in older people clinics. So if someone have unexplained hypoglycemia, he may have hypoglycemia because we don't know what's causing the hypoglycemia. He may be overtaking his medication. Maybe he is missing his meals. We don't know. So it could be dementia. So also dementia and the hypo, they are overlapping. We can be mistaken with the hypo and things. So any difficulties on this, it has raised the issue, has he got dementia? So dementia should be screened annually for diabetes people or sooner if they have some of this. And also practical points in care for dementia, I tried to put acronym how to look after these people. It's not easy. It's not easy to look after dementia, especially in type 1 and insulin. But this is just a practical help to see if this can be just avoided as possible. The most important, I put the bottom one, especially people, you give them insulin and then they not eat, especially short-acting insulin. It's important to give it after they eat. with the short acting, make sure they eat first and then give the opposite to normal what we do. Come to frailty, I think Professor Sinclair explained this. So a robust person has got nothing of this, but if you score 2 or less, you are in a stage of pre-frailty, which is a stage you can reverse frailty. But once you develop frailty, 3 or more, it's irreversible. It is progressive. It is a point of no return. So it's better to capture this earlier on. Now I go to this part is important. Reverse metabolism is something we taught before when we were medical students, that if you have cardiovascular risk factor, your mortality increase. So if you have high blood pressure, high blood sugar, obesity, high cholesterol, all this increase your risk in mortality, and the relationship is like a linear line, one line. The more you get, the more mortality is. But we notice in certain older people group, the curve or the line curve in a U-shaped relationship. So if you have high blood pressure, for example, or low blood pressure, mortality is high. Same thing if you have high BMI or body mass index or very low body mass index, mortality is high. It's a way we call reverse metabolism. What used to be a risk factor, it becoming a protective factor. In certain group, not every older people, in certain group, we think they are the frail people. And this is also interesting in how we treat diabetes in older people who are frail. So this U-shaped, you can see the mortality. It has been demonstrated for BMI. So if you lose weight as something of lifestyle, there is a limit how far you go. Because if you go below a certain level, you still have mortality.
If you lower the microphone about 6 inches. No, nearer your chest.
Near my is this better? Better, yeah. Thank you. Thank you. So this weight loss, you can see the people who are young people, you can see more or less like linear line. The more weight you high, the high mortality. But when you are above 65, you can see the start of a U-shaped thing. So if you get older, being very low weight, it may be a risk of you having high mortality. The same thing for hemoglobin A1C, you get U-shaped as well. When we were medical registrar, been taught that the lower the better in everything. Lower cholesterol, lower blood pressure, lower A1C is good for you. But now we start to see the curve. The lower can be increasing risk of mortality, especially in older people, either people on insulin or taking oral tablets. The same thing, this cholesterol is busy slide, you don't need to worry about it, but it shows that the relationship between cholesterol and mortality is not a linear, not the lower the better. So these are above the age of 80. We know below the age of 80, cholesterol lowering is effective, but above the age of 80 is not very clear. The same thing with the systolic blood pressure. The lower the better, but this observational studies showed people who are above the age of 85, they are 160 is the best blood pressure. Not many people in clinical trials are above the age of 85. So these are observational studies, show some other new evidence, how aggressive we are in our treatment. So this is the other thing. Now we wrote this one. This reverse metabolism, we don't think that low hemoglobin A1C is causing mortality. We think low hemoglobin A1C happen with people who are malnourished, having lost weight, and these morbidities are marker of mortality rather than a cause of mortality. So people having cholesterol of 2, they may be malnourished. Having albumin of 20 of something, low body weight and low hemoglobin A1C, these are marker of malnutrition rather than a cause of mortality. So we think virility is a confounding factor. Virility comorbidities are direct cause of increased mortality, and these markers are just marker of poor health or frail, in other words, if you like. So it's not really the low A1C, low albumin, it is the frailty is the cause of mortality. Here, when we say that, because of this U-shaped, can we actually reduce the hypoglycemic medications? And at the time, it was 2014 is published, but before that, we've seen this patient. In my clinic, I stopped the treatment for some patients, including insulin, type 2 diabetes, not type 1. And over the years, I thought I stopped some patients. Should I look at them together? So I found I have 8 patients. I stopped all their medication completely. And this is the zero, tell us the point of stopping hypoglycemic therapy. And this is hemoglobin A1C 6 months before to 12 months afterwards. So it's been followed up 12 months after stopping medication. And you can see hemoglobin A1C in 8 patients is flat, haven't changed. So at the time, Fertility wasn't really famous. We just, if I go back to this title, I will put frail older people here. But Fertility wasn't at the time common things. So I will put frail older people here because it wasn't common to stop medication for diabetes, something we didn't know about much. But now it's common, very common. So when I looked at them again, P means patient 1 and 2, you see the weight in the medical note, this is the peak weight they have, 100 kilograms, for example. At the time when I stopped them, he was 70 kilograms. So every patient has lost significant weight. I did not measure fertility because we were not aware of fertility at the time, but the weight loss was the major issue. And I think this was behind the success of stopping medication. Also, they are all very elderly, 86 years old average, and 4 of them, 50%, developed dementia at this time. So if I go back to this patient, I'm sure they are all frail. Now, consider the intensification. I think this slide shown by Professor Sinclair. So if you want to reduce tablet or withdraw it completely, these are criteria to de-intensify, just the acronym to help us if someone has this tight control, A1C, or recurrent episodes of hypoglycemia, it will raise alarm. Is this patient, does he need these medications? And gradually de-intensify. Now, the pharmacologic intervention, the medication therapy, I will not go through all of this, but we don't use sulfonylureas anymore. It is high risk of hypos in elder people. It's not out of fashion now, we don't use it. And meglitinide, the same thing. There's still metformin we use as a first line. And I will focus on the new therapy, on this one. The new therapy is these 2 medications, the sodium glucose transporter inhibitor and glucagon-like peptide 1 receptor agonist. These are the 2 ones coming up. And this is a mechanism of action. Briefly, they suppress appetite center in the brain. We eat less. They slow gastric mobility or emptying, so we remain full or not hungry for some time. And also they stimulate the pancreas to release insulin only when you eat. So it is glucose dependent. It is a physiologic work. This is not really, that's why it don't cause hypoglycemia. They are also inhibit glucagon while we are eating. So they reduce hyperglycemia. They don't cause hypoglycemia. They just reduce high blood sugar. The sodium, they work peripherally in the kidney. They release glucose in the urine. So when you lose glucose in the urine, your blood sugar goes down. And also you lose calories, so you lose weight. So these are the new medications. And the interest on this one, not only because they are similar to placebo, don't cause hypoglycemia, but they found to have very good outcome in protecting the heart event and also the kidney failure. So they are now the most effective medication to reduce cardiovascular risks and also renal failure and delay the development of end-stage renal disease, dialysis, or kidney transplants. So we said that about frail older people, because when the guideline first came with this new therapy, there was no clear, is it possible for frail older people? So we published this one, we reviewed the studies, And we said this therapy should be considered for frail older people, but not all frail older people. We'll come to this, not all the frail, because the frailty should not be one category. It is different groups. So we looked at it. Frailty could be metabolic spectrum. Before we move this one, you have 5 criteria for frailty. You need 3 to be frail. Weight loss is one of them. So if you take weight loss out of the equation, you don't need to lose weight to be frail. So you can be frail and obese same time. So this is important. So we put like frailty is a spectrum of someone who is very obese at one side. And if you are frail, you will have what we call sarcopenia, because frailty and sarcopenia is quite very linked together. Most likely, if you are frail, you will lose muscles and things. So you have obesity and sarcopenia on one side, running through a spectrum to end up with a typical nursing home patient who is very malnourished, anorexic, and significant weight loss. We call it anorexic malnourished. And in between will be grades. So this new therapy should be useful in people who are frail but obese and sarcopenic. If you are obese and sarcopenic, your cardiovascular risk is very high because you have a lot of insulin resistance. Because you have sarcopenia, you have less muscles. This is where we use our glucose. If you have less muscles, your insulin resistance will be high. If you are fat, you have fat mainly in the viscera, increasing insulin resistance. So these medications are important in this group of people. But if you are anorexic, malnourished, with weight loss and low blood pressure, and not eating, this tablet may make it worse. That's why we said this medication should be useful in sarcopenic obese people, but not in anorexic malnourished. So we put here glycemic target should be driven by individual function. You go tight for someone who is fit and relax for someone not fit. But a choice of therapy should be driven by metabolic phenotype of frailty, if you are either sarcopenic obese or anorexic malnourished. This is what we said. And we elaborated more in another paper, metabolic characteristics of frail older people. And the conclusion is, the evidence suggests that frailty is a heterogeneous condition from metabolic point of view. It's not just one category. And this therapy should be considered in people who are sarcopenic obese. This is the diagram we have to put it, and this diagram is published, although it looks like a funny thing, but it's published as it is. So this is the big one, and this is the thin one. And metabolically, you can see they are different. So this one, you may have good serum albumin, good serum cholesterol, good hemoglobin, A1C will be high, blood glucose high, blood pressure high. All of them are statin and fibrate. These are a summary of the clinical trials. We looked at all the clinical trials who reported low hemoglobin A1C in some cohort and high hemoglobin A1C in another, and we find they are actually fitting into this too. And people who, there is a lot of studies, they intensified hypoglycemic therapy and stopped it. And I looked at these people, they are all thin, anorexic, malnourished characteristic of the frailty people. So this is where the intensification happened on this phenotype, not in this one. Not only this frailty also can change diabetes trajectory. Diabetes is a progressive disease. We know that it progresses over the years, but this can be accelerated. If you are anorexic, malnourished, or sarcopenic obese phenotype, diabetes trajectory could be accelerated because you have enhanced insulin resistance, and this may increase your diabetes quickly, get worse. The opposite, if you are anorexic, malnourished, you have a regression of diabetes course. Imagine someone has done a bariatric surgery and his diabetes cured. Or someone had severe diet and he lost a lot of weight and diabetes become in remission. We don't use the word remission for older people because if you have anorexic, malnourished phenotype and diabetes gone, is not good news. It's not remission is a good word, but in frail older people, diabetes is gone, burnout, but is not in a remission a good word. Is medically it is bad news. It means you are very frail, and it is a mortality marker. If you have lost a lot of weight, you have anorexia, and you have low albumin and low cholesterol. These are mortality markers. So it's not, although it looks like good, diabetes is gone, but it is poor news. So we said diabetes trajectory, frailty split diabetes into aggressive one and the regressive one. So now before I go this one, that's why therapy in the sarcopenic obese, we should be focused on intensification of therapy and prevention of cardiovascular disease. And the anorexic malnourished, we should be focused on de-intensification. And quality of life is the aim. Now we come to these papers, diabetes care. And this paper just come recently. And there is no good studies included fertility as an outcome. This study is just a retrospective analysis of previous data to look at fertility retrospectively. So it's not a good quality data there. But this is the conclusions you have. Here, sodium glucose and GLP safely improve cardiovascular outcome and all-cause mortality with the largest absolute benefit among frail people. So this conclusion is inaccurate. Although it is frail older people is correct, but not all frail older people. So if I looked at it, they put it in the supplement. So you go to the supplement, and what frail people they include? 5,000 frail, 50,000 non-frail. I just focus on the red ones. The frail people are more overweight. You can say 12% compared to 9. Obesity, 49% compared to 29. So the frail they include, they are actually well-fed frail, if you like, obese ones. Obstructive sleep apnea, OSA, common on the frail group, 31, means they are more obese, right? And also you get GORD or gastroesophageal reflux disease. You get it like heartburn on acid, common in frail and obese people. So the frail people they include tend to be good weight or overweight or obese. That's why they have good benefit from these things. So they are not the whole group. And this study in particular excluded the nursing home patients, the one we think are more anorexic malnourished. Not only that, people who have one episode of nursing home admission in the last year was excluded. So the cases they include are actually good frail people, not nursing home, the obese ones. So this is comparison of sodium glucose with DPP-4. And this one, similar, comparison of GLP, same study with DPP-4, the same group, overweight, obesity, and obstructive sleep apnea is more there. Also, GORD is there. I didn't highlight it red, forget. I'm getting old now. Someone said I'm getting old, forgetting, but the same thing. They are not the anorexic malnourished group. This is another study, which is a cardiac study. This is heart failure study, is not diabetes population, just heart failure. And sodium glucose have benefit on these studies, but the same thing. Their conclusion is benefit of dapagliflozin is one of the sodium glucose inhibitor, consistent across range of frailty studied. Improvement in health-related quality of life with dapagliflozin occurred early, was greater in patients with high level of frailty. The same thing in conclusion, just word frailty to all of people is also not accurate. The same thing, this is the frail people, how they define it. BMI here, 32, compared to non-frail, and significance is there. So they are actually obese people. Obstructive sleep apnea is the same. Although they are not diabetic, but the frail people here with diabetes, about many people have diabetes. Did I put it? 70% type 2 diabetes, yes, is about 72% have diabetes on the frail group. So it does apply to diabetes people, 72% diabetes. Another study, also heart failure, similar thing, but another heart failure with post-hoc analysis. Very similar conclusion, dapagliflozin is good regardless of frailty status. and everyone frail. I think these conclusions are not accurate. You cannot have this, go to a care home, people who are malnourished, very weak, and apply this medication. Frailty here does not represent all frail people. It represents subgroup of people who are good weight. And here's the same thing, and compare non-frail, more frail, and most frail. I put the most frail here. BMI is 30, it's very obvious. And again, obstructive sleep apnea is higher here. So the group are actually good, well-fed people, although they are frail. So what we conclude previously is this medication apply only to sarcopenic obese people rather than anorexic malnourished frail people. Here's a glycemic target we want to consider. I think Professor Sinclair showed something similar, but this one may be slightly different. Independent, partially dependent, fully dependent. This is a definition we put it. And control could be tight, could be relaxed, could be here just symptomatic. A1C numbers, you can agree or disagree, but this is above this number, you can get worse things, but I put here asterisks because these people are care home. The focus in short blood sugar control rather than long term, because life expectancy is short and A1C may not have much weight than people who are a bit expected to live longer. So the focus on BM or blood sugar, I put here between 6 and 15. Below 6, you may get risk of hypo. Above 15, you may be confused. And the main issue here is to avoid hospitalization. This is the main issue, quality of life. And the main adverse event for this group is to admit them with hyper or hypoglycemia. So focus on the short-term blood glucose more important than A1C. And this is graph, I just put it as a guidance how to use the new therapy. I put anorexic malnourished at one end and frailty spectrum there, and sarcopenic obese on the other end. And if you are anorexic malnourished, you are likely to be a reverse metabolism. Your diabetes is shifting backward with reduced cholesterol, low blood pressure, low A1C, kidney failure. And the target here is just to de-intensify therapy and use quality of life as an issue. The other side, you will have intensification. Cardiovascular risk is important. And this is the criteria. BMI will be high on this side, be very low, and you have in between. So not all will be polarized in two groups, but will be somebody in the middle, and you're just considering it. So end of life, I just add this because of things. If people get care home, I just put it simplifying things. It depends how you expect life expectancy is a bit subjective, but simply if you put it in weeks, you may consider switching everything to insulin long-acting. Type 1, obviously, you keep the long-acting on. If life expectancy is days, you may stop everything in type 2, continue the long-acting in type 1. If you think people dying in hours or people unconscious, you stop everything. So I think I forget to put a conclusion slide. So I conclude here, and thank you very much.
Thank you very much indeed for that absolutely superb lecture on real world management of patients with and our elderly population and how we should rationalize treatment. Now I'll ask the speakers to sit down, and now we'll take some questions. So do we have a roving microphone? Is that working? Okay, right. So maybe people will, I don't know whether it is mobile or detachable or it's not detachable. Okay, you'll have to come and ask. Yeah, I think, yeah, it's mobile. Okay. Any questions? Well, right, Lindsay.
One is many of us with diabetes really find it going into care and nursing home or even having a care at home because of the difficulties of getting nursing treatment. Do you ever see people who are very dependent? Do you see people in nursing homes, in care homes, and comment on their care? I mean, how supported are they by experts?
Can I answer this?
One of the things that people
Yeah.
have said, the lady that one of her said, her husband had type 1 and died this year, and she was really horrified about his care in the nursing home, and it's made her very frightened about her own future.
Yeah. I th-
I'm really sorry, I think this was talking about.
well, I have some comment on this. Excuse me, Professor Frank. Well, I think I've seen people with type 1 who are in their 80s and they manage their blood sugar, they still do BM and everything, and they come to clinics. Also, I've seen them inpatient in hospital, and they prefer to manage their own insulin in hospital rather than nurses. And I will encourage them to use it. They are more accurate than nurses. They know their diabetes more better. I have a lady now, she has 50 plus years of diabetes, and we talk. I told her, you know more than diabetes than me and the team with me. You know better. So you manage your own insulin in hospital. So the same will apply in care home. The only difficulties appear when you have disabilities, either mentally or physically, and you cannot inject yourself. This is a difficulty. But as long as you are capable of doing it, you should be able to do it wherever you are. And this is the best for you is yourself, because you will know if you feel you are hypo or not. You recognize the symptom more than anyone else. So even if you are going to a care home, you should have self-administration of your own insulin. Care for people who have lacking capacity, mentally or physically, this is a problem. This is a problem. With people with dementia, the main issue is eating. If you have dementia and you're eating regularly and you are awake and have no swallowing problems and you're eating regular, it shouldn't be a problem. Nurses can give it to you. Difficulty appear when advanced dementia. When you have behavior problems, refuse the injection, get agitated, or you don't eat, hit and miss. So this is the difficulties. Not everyone like this, will be small, exceptional, but these people, as I said, short-acting insulin administered after meal consumption rather than before that. And you don't eat, you miss the insulin. If you eat, you take the insulin on a PRN basis, if you like.
Debbie, do you want to comment? Because we have diabetes specialist nurses here in the community. How do you link with to upskill the staff in nursing homes? How do you support people in?
Yeah, so across Sheffield now, the inpatient, the outpatient nurses definitely manage type 1 diabetes. And ourselves, myself and Bridget and the rest of our team support the patients with type 2 diabetes. We now have very regular meetings with district nursing teams to support district nurses manage people in their own homes. And we also support nursing homes so they can have access to us and refer any point there. We want to encourage people to do that. We encourage people to do that. And obviously, if you've got any family members in there and you feel they're not getting that, then please bring that to our attention, bring it to the nurses and the nursing homes attention, because they can refer to us at any point. Just want to add to that.
That's very helpful information. Question then. Wait for the microphone.
Rauf Kiani. I'm looking from, the question is from a perspective of a carer. I cared for my elderly parents for 10 years, mum first. She had schizophrenia, and then dad for 3.5 years before he passed away. And that was following his stroke in August 19. And I have seen Mr. Ahmed, what you have described vis-a-vis people deteriorating, gradually losing muscle tone, etc. And in terms of me as a carer, I found it very helpful to be in touch with the district nurses if I was concerned about dad's insulin levels, and they would say, "Don't worry, we'll come and take you through." So I sort of concur with you, Mr. Ahmed Abdullah. So I have seen that physically, uh, and I too am a diabetic. However, one thing that I have done as an educated man is to take control of my own diabetes. I've attended every course that my diabetic nurse prescribed, my GPs prescribed, and I'm based with my GPs are at Holly's Medical Center, and they've been the most supportive of doctors and diabetic nurses. So much so that 10 years ago, I was 15 and a half stones, and today, 15 and a half stones equates to a huge number of kilos. And now I am 9 stones 10, and I've come down 3 super sizes from 42 to standard 38 weight from 42. So I'm a walking example of gaining control of your own life with determination. But the art is to maintain. We as human beings are habits creatures, but I can testify that we can change our habits, reinstate new ones, but the difficulty is to maintain and sustain them over time.
Thank you very much for that reflection. While you're thinking, yeah, okay, another question?
Question about the care home environment. In a past life, I was an inspector with the Care Quality Commission. So thinking about how can we improve the training that is provided to care home staff, given that the care home industry and getting good staff and keeping good staff is a real difficulty. So what can we do differently to actually get the right training and not just train, but move people into better practice?
Well, it's an excellent question, and one that has been asked for the last 2 decades, and still there's a lack of real improvement in the training and education provided in care homes. Now, the important point to remember is that the majority of care homes are private. And you have to, as a private businessman, lady, you have to decide where you want your profits, your income to be spent. And unless there are strong regulations from the Care Quality Commission or the government in relation to the management of diabetes, and don't forget, it's one of 8 or 9 comorbidities they have, so you have to make a special case in a way for diabetes, although 1 in 4 people in a care home of diabetes, they may not want to spend money on allowing their care staff to take time off to be taught, to be educated, and so on. They may not do unless they're pressured to do. Now, that's not that doesn't necessarily relate to all care homes, because there are many care homes, and there's some regional variation, but there are many care homes who invest in training courses, training programs, and it depends on what area of the country you're in, and it depends on usually 1 or 2 specific champions within those care homes. And I've been involved in running some of those courses along with a colleague of mine called Lynn Reedman, and we have done courses in Wales and in other parts of England, and they've usually been over 2 full days or 3 days, and it's been a significant investment for the owners of those care homes to allow their staff to go. And until we do audits or until we do research, we will never know if it really has a proper impact. So we have to keep pushing. And one of the reasons for setting up the National Advisory Panel Care Home Diabetes is to bring about that change. It's still a bit too early, but there is evidence that, you know, they're using some of the criteria within that document, and I urge you to read that document, to set up their own audits and to see about it bringing improvements in diabetes care. We have a working subgroup of the National Advisory Panel have recently produced a paper on the guidance on managing type 1 diabetes in care homes. And we're hoping, and I won't say any more, but we're hoping to have that published quite soon, and that will be available to you. But I'm sorry, it continuous pressure, and it is people in the community, as well as health personnel, who have to keep pressurizing and pushing for that change.
Thank you very much. I think there's a question from the back. 2 questions. Short questions, short answers, please. We've only got 10 more minutes and to finish. So,
hi, I just wanted to say something a bit reassuring about this. I'm very nervous from the Integrated Care Board, the NHS strategic planning part of the NHS here in Sheffield. I don't know much about this, but we do have a quality in care homes team that is clinically led. They are taking part in a national programme called Enhanced Healthcare in Care Homes. And we do have a dietitian who provides clinical advice to care homes. I'm sure it's not enough, but we have got that. And I just wanted to ask a question about public health messages about ageing, thinking about people who are pre-frail. We're hearing a lot more now about the importance of resistance training, weight training, menopause, or ladies should be down the gym, I am, and the importance of that for the diabetic group, and what might be your public health messages that you might want to say to people who are still quite young, on the younger side of old. What should they be doing to look after themselves?
The only thing I say, keep your muscle healthy. The key is the muscle. We underestimate the importance of the muscle. The muscle, although we think it is a mechanical thing, get us from A to B, actually the muscle is an endocrine organ. And when you exercise, the muscle secretes some hormones or so-called myokines. These are cardioprotective. Opposite, if you are obese, you're having too much adipose tissue, you secrete some pro-inflammatory hormones called adipokines. And if you have imbalanced muscle fat ratio in favor of more fat, you will get the more adipokines than myokines, and this put you at high cardiovascular risk and all factors. If you keep your muscle healthy and you have myokine or muscle mass ratio in a healthy position, you have a protective effect for cardiovascular events. So the muscle is the key. Muscle mass, we call it, and muscle function, muscle strength.
How do we, I mean, the question is, we don't diagnose frailty in primary care. I don't know whether that's done with other diagnoses. Because I think one thing I learned today from both speakers is that actually if you diagnose it, you can do something about it to try and reverse it. But it is not a formal diagnosis as such. So my question to the speakers is, should we have a proper diagnose as a diagnostic thing on the GP template, type 1 diabetes, type 2 diabetes, frailty, maybe, or pre-frailty, stage 1, stage 2, I don't know. Should we have that? And if we diagnose it, what are we going to do about it? Can we prescribe
Yeah.
something for these patients? Are the community programs?
Mm.
I mean, you were telling me today that you have a Tai Chi lessons for, you know, is it well publicized? Should people be on walking groups? Because I think if we prevent people coming into hospital, it would save the NHS a lot of money. Alan.
Well, Solomon, let me, perhaps I didn't clarify it too much in my talk, but for a few years now, the quality outcome framework, which GPs are involved with and determines much of their checklist work, so to speak, of measuring blood pressure, blood glucose, and all the other quality standards, is a standard for frailty, is embedded in that, and that follows work we did on frailty assessment and the importance of frailty. And there are several standards, and GPs, as you know, have about 5 income streams from the different sources, but one is obviously they get for points or funding for carrying out various checklists of assessment and identification. Now, the only problem is that in people above the age of 65, this is the standard that you have to look for frailty in primary care. But the point is, even if you find it, they don't tell you much about the levels of frailty, because there's not a lot of work on that. And secondly, they don't tell you what to do. So you're down in a way to normal age-related modifications of lifestyle and so on, and it's speculative. There is no real public health message apart from staying healthy. And just going back to what Ahmed said, I've always believed that diabetes is a disease of muscle, primarily. And so Ahmed is absolutely right that the focus should be on keeping muscles active and strong. And in diabetes, we know that as soon as you get diabetes, you lose muscle. You get an accelerated loss of muscle. And it is only through resistance training and those types of exercises that you can build that up. But if you let your glucose levels go and you let your blood pressure go, metabolically, the muscle becomes very poor responding to these lifestyle measures. And so it's not an isolated phenomenon.
That's a lovely answer. Question at the back.
This is a quick question. For older adults, of which I'm one, could you just comment on the greater use of, technology? Could you just have a few extra comments on, for example, blood glucose monitors? Because we have not encountered that very much for younger, older adults. But I just am wondering how proactive people might want to be about that, or your views on that.
Can you please, is the microphone working properly?
Is it working? Okay. Could you just add a few comments about the proactive investigation or use of the blood glucose monitors, the technology assists? I am asking with reference to older people, but the younger older people.
Okay.
Well, I mean, NICE have criteria for recommending continuous glucose monitoring and having it available to people with type 1 diabetes who need intensive monitoring. In fact, I think they state that you have to be monitoring your glucose level at least 8 times per day, and it has to be in the last 3 months of at the time of your review. For pregnant women, obviously with type 1 diabetes, people with type 1 diabetes are unable to routinely self-monitor due to disability, for example. And as you know, I think you might have been self-funding your Freestyle Libre, but as far as April 2019, it can be considered for NHS funding. So you have to have a past history of use. So those are the criteria. What I tried to show in my talk was just a few of the benefits of having continuous glucose monitoring. And I think that if there's anything more that you need in that, we'll come down after the session and talk to us. Okay, is that all right, Simon?
I think we've gone on. One more question that Ewan McKinnon, his great wife was the lady who started, actually introduced GPs in Sheffield. Mrs. Mary McKinnon, she started this community education, upskilling, general practice. So Ewan.
Simon, is that on?
It is.
It's very difficult to know when you're speaking. I'm not going to ask you a question, so you don't need to bother to listen if you don't want to. But may I make a comment? You're teaching so many people so well. My wife was in hospital, dislocated, 11 years ago, 10 years ago. We've lost we keep losing your microphone. She was given a gross overdose of insulin. Fortunately, of all the patients in the ward, she knew what to do. I didn't say the nurses. I sat by her bed, and another staff nurse came. Staff nurse, trained in diabetes. And I said to Mary, she's frightened of diabetes. And Mary said, quite so. That, I'm afraid to say, from talk at this group, I have recognized that many people delivering diabetes care, even though trained, are frightened of diabetes. And I think that is where a big, big problem lies.
Thank you. Final comment from you, and then I think we'll bring the meeting to a close. Did you want to comment? Did you want to comment?
Yes. Tom and I have started a support thing on X or Twitter called Diabetes Chat, and we get clinicians to speak. I think peer support over the next sort of 4 or 5 years is massive. I spoke to Partha Carr 2 weeks ago in Portsmouth, and he's all for it, because peer support, you can speak to like-minded people that have type 1 diabetes, have other illnesses, and some we've got kidney problems, sight problems, but peer support is a massive help going forward, I think. And I think maybe the NHS ought to have a look at that and see how we can be of value going forward. You know, in France they're called patient advocates. So if somebody's in hospital with say chronic kidney disease or something, people with that illness that have had it for 10, 20 years can then liaise with them and speak to them and share the problem, and often it lifts the souls, and it's not as daunting and it's not as worrying and stuff like that. And I think probably peer support is a real tool for the next sort of decade, I think, you know.
Thank you very much. Right. I'd now like to bring this meeting to a close and want to thank very much our 2 brilliant speakers. Can we give them a warm applause? I would also like to thank Lindsay, Shirley, and Josie, and others, Diabetes UK team in Sheffield, who really planned this, organized the whole thing, publicized it. It really is amazing, and let's just give them a nice round of applause. So with that, thank you very much for coming. Thank you very much for attending, both the people who are here and also online, and thank you very much.